students, welcome to this session. So now I will discuss Unit 2 of the topic Evolution of Healthcare. So I've told you the objectives of this topic earlier, and this is the second unit, National Health Mission, covering competency 16.4 and 17.4. And the objectives that I'll cover here are the existing drawbacks in the health system, the priority states, vision and outcome, expected outcome of the mission, institutional mechanism, and the strategies. So this is the logo of National Health Mission. In the year 2005, on 12th April, the National Rural Health Mission was launched. That time the idea was that another similar mission, the National Urban Health Mission, will be launched subsequently. So this National Urban Health Mission was launched on 1st May 2013, and that time only these two were not kept as two separate missions, but they were combined as subunits of the main National Health Mission. So National Health Mission itself was launched on 2013 1st May with two sub-components, National Rural Health Mission and National Urban Health Mission. So presently both these missions are being implemented as the National Health Mission. Special focus is given on 18 states, that is 8 Empowered Action Group states, these are the ones, 8 Northeastern states, these, and 2 other states, Himachal and Jammu and Kashmir. So drawbacks that existed in the present system that time is the centralized planning was happening instead of decentralized planning. Institutions were based on population norms rather than habitations. Then disease-specific approach was going on rather than comprehensive healthcare. And the health-related components were not delivered properly. And public health expenditure was very low. It was 0.9% of GDP in 1999. So the vision was to attain universal access to equitable, affordable and quality healthcare services, accountable and responsive to the needs of the people, with effective intersectoral convergent action, and to address the wider social determinants of health. So these were the expected outcomes of NHM to be achieved by 2017. You have to remember all these. The institutional mechanism at the national level, National Health Mission is headed by the mission director and supported by a team of joint secretaries. Then there is the mission steering group that is chaired by the Union Minister of Health and Family Welfare. And as technical support, there is the National Health Systems Resource Center. And for training support, there is the National Institute of Health and Family Welfare. At the state level, there is the State Health Mission headed by the Chief Minister. There is a State Health Society headed by Chief Secretary. Then the technical support is provided by the State Program Management Unit, State Health Systems Resource Center and State Institute of Health and Family Welfare. Similarly, in the district, there is the District Health Mission or City Health Mission running, which is headed by the chairperson of the local self-government, Zila Parishad, or mayor of the municipal corporation. I will discuss local self-government in another topic. Then there is the District Health Society, District Program Management Unit and District Public Health Resource Center. Management of public health institutions, for that there is the Village Health Sanitation and Nutrition Committee, VHSNC, at the village and sub-center level, and primary health center and upwards level there is the Rogi Kalyan Samiti or Hospital Management Committee. So these committees have representatives from the health provider side, that is the health facility, and also from the health beneficiary side or the community. So representatives from elected bodies like Panchayat, Panchayat Samiti, Zila Parishad, etc. And this system, that is a committee formed from both stakeholders, it helps to enhance decentralized planning, community participation and public control, because the public is involved in this, and maintaining accountability. So now the strategies of National Health Mission. First is integration. So all the existing vertical programs will be integrated and implemented under the common umbrella of National Health Mission. Only the National AIDS Control Program will not be under this. This will be a separate one, and there is a separate Department of AIDS Control under the Ministry of Health and Family Welfare. And convergence of the major determinants of health, that is water supply, sanitation, hygiene and nutrition, WASH and nutrition. Then next is there will be decentralized planning. So health planning will start at the village level by the VHSNC. I have told you how bottom-up planning happens in the context of fixing targets for family welfare. So similarly, the plans, the general health plan will be made in the same way, bottom-up. That is decentralized planning. So the first village level plan will be made at the VHSNC with Asha, Anganwadi worker, the multipurpose worker, male and female, all together they'll make the village health plan and the sub-center plan. And these together will make the PHC plan, and from that the block plan, then the intersectoral district health plan, and subsequently all together the state program implementation plan. So that is bottom-up planning. So, or decentralized planning. So this is how it will happen. Village, block and city health plans. These together will make the intersectoral district health plans, and that will make the state program implementation plan or state PIP. Next strategy is facility-based service delivery. The focus will be on development of infrastructure, health personnel, logistics, drugs and supplies. Quality assurance is very important. And new construction of health facilities will be based on population norms, of course, how much population it has to cater to. In addition, utilization of existing facilities, then the disease burden in the area. So the more the disease burden, more infrastructure and facilities will be required, and existence of other public and private facilities in the area. Then for facility-based service delivery, strengthening of all the existing facilities will happen. District hospitals with 500 beds will be there for 10 lakh population, and there will be Rogi Kalyan Samitis for accountability and common platform. Then grievance redressal system, that is when the people will have any complaints on grievances, they can lodge their complaints somewhere. So this is the grievance redressal system which will look into these complaints and find solutions and work it out. And active engagement of the local people, that is through Panchayati Raj institutions in rural areas or urban local bodies in urban areas. Ayush facilities, as I said earlier, will be incorporated into this, integrated. And another important thing has been introduced, that is a citizens charter. So this is a list of services that are available at that health facility. So this will be displayed at every health facility so that the people remain informed as to what they will get here, what they can expect to get here. It also helps the health providers that people will not be able to or should not demand anything beyond that. Like in a PHC, when it is written that only normal deliveries happen here, people cannot demand cesarean section. So where there is a complication and it requires cesarean section, the lady will be referred. So people have to understand that this is not a part of service assured provided at this health facility. So next is Kayakal. This is a very nice system introduced into it to promote cleanliness in the public health facilities. So a cash award with a citation is given to the best health facilities, and these are the numbers, that is 2 district hospitals in each state, 2 community health centers or sub-district hospitals, and 1 primary health center in every district. So the objectives are to promote cleanliness, hygiene, infection control practices, to incentivize and recognize exemplary performance. So when they are striving to maintain cleanliness, so this is a healthy competition where they are recognized for such good service, and continue ongoing performance, and to create and share sustainable practices. So this cleanliness, this promotion of cleanliness and maintenance of cleanliness should be a sustainable activity. Next is the district hospital and knowledge center. So this provides all care, clinical care, laboratory care, skill-based service, support for training, then data management, etc. Then next, another one is District Public Health Resource Center. So this is a multidisciplinary team providing technical inputs on all the various aspects. And the District Education and Training Center for education of the nurses, allied health professionals and the mid-level providers. Next strategy is outreach services. So in rural areas, outreach services provided through Anganwadi Center, through the Ashas, etc. In urban areas through ANMs based in urban primary health centers. And there will be a mid-level provider, as I've said, with a BSc qualification in public health, BSc nursing, etc. or community health. And there will be a link between the health supervisor and ANMs and the doctors. There will be mobile medical units for providing service to hard to reach areas. And behaviors change communication is the next strategy, which is always very important and it should be promoted actively. Then use of information technology. So this is an application, Anmol ANM Online. Anmol is a tablet-based application for helping in service delivery. So this can work on offline as well as online mode. And here Aadhaar enabled authentication is done and the ANM can work on it. It provides guidance to the ANM and it helps to standardize the services, maternal and childcare services. The ANM can plan the services, generate work plans, and thus time will be saved, quality of care will be improved. And there is also audio and video counseling system in this, so which can be used for awareness generation for the community. Another IT-based technology is Kilkari. Kilkari, the word means a baby's gurgle. So this involves delivering free messages, weekly messages. So total 72 messages are sent. These are sent on the family telephone number that has been given, time appropriate. So at the particular point of time, whatever message has to be conveyed is given through this. So this starts in second trimester of pregnancy and continues throughout pregnancy and up to 1 year age of the child. So it gives messages on pregnancy, on childbirth, child care, immunization, nutrition, etc. Another system is Mobile Academy. So this is a training course, a free audio training course for Ashas. And the benefit is that the Asha can attend this training at her own pace, at her own time. It's not a fixed time-bound activity. It is a flexible one. So at her own pace and whenever it is convenient for her, she can attend to this and complete her training.